Well, good morning. Thanks for being here today. Pleasure to speak with you. We'll talk about really two things. One is the state of mental health, or really untreated mental health, and then a little bit about how Learn to Live as a company, a Minneapolis-based company, is addressing that. So we'll start with a little bit more about Learn to Live, but we've been operating since 2013. We're fortunate to have thousands now of alumni of our programs and services. We cover about 2 million lives. And we work very closely with health plans, higher education institutions, and employers. We provide something called online CBT, or cognitive behavioral therapy. So if you're familiar with mental health treatment, CBT is regarded as the highest fidelity, highest form, best form of face-to-face therapy. And as it turns out, online CBT, if it's done correctly, can be very, very effective for treating people in mild to moderate suffering. And that is what Learn to Live does. We have very strong ties to Minnesota. So as you can see on the screen, we're very proud to work with employers, work with higher education institutions, work with health plans, and we serve populations as small as 1,000 employees up to the hundreds of thousands. And so an exciting feature of what we do is that it's highly scalable, and that really feeds to our mission of reaching the 3 out of 4 sufferers who generally won't go in and seek out face-to-face therapy. And that's really what this graphic here is about, is that almost half the people in the United States will suffer from a mental health problem at some point in their lives, but sadly only 1 in 4 will seek out face-to-face therapy. So in the state of Minnesota, or even in this room, we can imagine roughly 50%, and then of that, three-quarters of them won't seek out that face-to-face therapy. Why is that? Social stigma is still the #1 barrier to seeking out traditional forms of treatment. Number 2 is access. So that can be, you live in rural Minnesota, there's maybe one provider in your county. Or it could be that you live in the metro and you just face a 3 or 4 month waiting list, or the therapist that's the right fit for you isn't available on nights and weekends, and you can't get off of work for it. So access is a very real thing. Cost is another. So many therapists now, to be able to afford to practice because of the way the reimbursement system is designed, they don't accept health insurance. And so sufferers are faced with paying directly out of pocket, which can be formidable for them. So I have a whole bunch of stats here that really speak to, it's not just the plight of someone who's suffering so much that maybe they have social anxiety, they can't get on the bus and go to work. It's the organizations that also face these problems, because then they see the cost and the problems associated with that suffering. So with employers, it can be anything from reduced productivity to high absenteeism to 50% generally of disability claims are due to mental health problems. And so all of these things can add up in pretty significant ways for employers. One other example here, individuals with depression who aren't receiving care consume at least 4 times the healthcare resources of other employees. So if you imagine a self-insured employer, most employers in Minnesota are self-insured, at least the larger ones. That's very, very costly. We do a lot of work in higher education. So students, as you can imagine, face at times overwhelming anxiety. Depression is unfortunately becoming more and more common on campus. And what that means for higher education institutions in the worst case scenario is that these students drop out. And attrition is the #1 cost driver for colleges and universities. And they're always trying to find ways to deal with that. And mental health is one of the, if not the biggest driver for most colleges and universities of that attrition. And that's where we come in as well. How are we the same or different than other services? We're really complementary to counseling services, face-to-face services. You may have heard of something called employee assistance program services, which many employers have, where employees and their family members can use a phone counseling service. Those can work for some, but unfortunately, social stigma or fear of discrimination in the workplace can be a big driver of lack of utilization and lack of use of those programs. And so we really sit outside of that. Again, our focus is to go after what we call the silent sufferers, those who will never present on any kind of clinical map for an employer or for a health plan, those who are, as we say, kind of staying in the shadows. And what we do is we go out and we find those folks, and we befriend them, and we get them to engage in our programs. So finally, we get to what it is that we do. We provide online self-directed programs right now for depression, social anxiety, stress, anxiety, and worry, and insomnia. So this is not a telehealth platform. This isn't, Skyping with my co-founder, Dr. Russ. These are self-directed programs, so highly interactive multimedia programs, usually 8 lessons per program. Each lesson's about 45 minutes. It's cross-device, and so students most often do it on their phones. Employees, it really can vary how they engage with us on the device side. But as they go through the programs, they're also given tasks and homework to do, really activities to do outside of what they're learning online, so they learn how to apply CBT tools to their day-to-day lives. And that's really the power of CBT. It's very practical, very tools-based. But we also have coaches. So we have psychologists on staff that are available 24/7 to provide encouragement to our members to stick with the program. And that's via text, via phone, via email, which has become a very powerful option. Our members have lots of choices. It's really consumer driven. So if someone wants to engage with us in the program and not engage in the peer-to-peer community, or not engage family members, something we call teammates, there's a teammates program, or not engage coaches, they don't have to. And so we have certain percentages that do that. And the whole idea there is, if you want to engage at 2 in the morning in relative anonymity and go through your program and deal with your mental health, you absolutely can do that. Most importantly, these programs are as effective as face-to-face therapy. So online CBT as a clinical body has been around for over 2 decades. So we have hundreds of gold standard clinical trials that show that for mild to moderate suffering, this kind of treatment is actually very effective. So if you can imagine that someone can be, and you'll see here a lot of clinical data across all of our members, but if they can reduce their depression by 30%, even in a face-to-face setting, that's a very, very good outcome. And so across what I call our book of business, or across our members, we see, and that's the bottom stat there, but drops of depression by 1/3, anxiety by 29%, that's the GAD-7 psychometric assessment. Sleep, so people's sleep improves by 30% on average. Social phobia inventory, it's called SPIN, that's for social anxiety, that's a little over 22%. So these are compelling improvements. So if you think of these improvements, that's the difference between someone being able to go on a date versus not go on a date. So it's very significant, especially if you think about higher education or employees in the workplace struggling to get their job done. I won't go through all of this. Dr. Russ always likes me to put this in there. But there are a lot of mental health problems that can be effectively addressed by online CBT. And so needless to say, we're not stopping at 4 programs. We have an ambitious build plan for many, many more programs. I've already mentioned most of these, but I think a big thing that we're seeing is we can also help folks who we would consider to be subclinical. So they're on their way to being clinically depressed, but they're not quite there clinically speaking, but they're still maybe starting to miss class, they're struggling with their studies. We play a very meaningful preventive role in keeping, kind of heading them off at the pass. We can help with chronic conditions. So you may know that for chronic physical conditions, 50% of people, say with heart disease, have a mental health problem. So if 75% of those are not being treated, that exacerbates their chronic conditions. So in our work with health plans, this becomes very significant because we can help people with chronic conditions as well. I think I've covered most of the rest of these, but we again can move the needle significantly on a number of cost areas for folks. One of the biggest things that we offer, in addition to reducing costs, is just very high engagement. So the University of Minnesota, for example, last year was our first year, almost, I think, 8,000 students out of the 55,000 engaged with us, and that's year 1. And when we say engagement, we mean completing a comprehensive assessment and/or enrolling and advancing in a program. So it's not enough that they enroll in a program. We only count them if they're actually taking steps forward. And we believe that's for a number of reasons. I think we like to think that we do some things in a unique way that enable sufferers to trust us and join our community. But at the end of the day, unfortunately too, it's a demand issue. And by offering something that's mobile, where we keep their identity from the sponsoring institution, this becomes a powerful way for someone to at least feel out the situation and try to deal with their mental health. We get asked a lot why it is that organizations partner with us. We believe it's for a number of reasons, but one is that we can meaningfully extend the reach of care. So if an employer is not seeing a lot of use with their behavioral health benefits that their employees have or their employee assistance program benefits, they can engage with us and they can see a 20 to 30% increase every year. So some of our first employer clients have been with us for 4 years, and we've seen that remain constant year over year. So high engagement rates. We have a lot of compelling clinical data. So our partnerships with Blue Cross Blue Shield of Minnesota, Blue Cross Blue Shield of North Dakota, Blue Cross Tennessee. As you can imagine, health plans do a lot of vetting with data, and the clinical data needs to be very solid and very compelling for health plans to put their names behind it. And that's an exciting thing about online CBT. We don't need to integrate on the technical side, so it's a very efficient delivery process. Again, we're complementary to other services, and we don't need to, everything's in-house. So we have full-time member coaches that can deal with all the members. I won't go through all this data, but this is kind of a 2-year study that was done with one of our employers, where in this case you can see that we meaningfully reduce the incidence of a major depression diagnosis across their population by about 25%. So we're not only meeting people where they are and helping them, but we're also helping people. In this case, they had fewer visits than in-office visits, which is saving costs. And again, it's easier for the sufferers because there's not the logistics, there's not the stigma associated with that. This speaks a little bit more to reducing the need for office visits, which has been a powerful thing. And then the other thing that's really interesting is, and compelling, is a lot of self-insured employers see a really high cost in ER visits for panic attacks, as an example. So as you may know, if you go to the ER and it's not life-threatening, the cost is very different than if there's a life-threatening situation. And so with a panic attack, unfortunately, it's a very costly visit, and we're able to really reduce those pretty significantly for employers. I won't go into all the details, but the University of Minnesota is one of our partners. We're in our 2nd year with them, and so this talks a little bit about how we worked with them in our first year and rolled out across 5 campuses in the state, 55,000 students. And what we see here is some pretty dramatic improvements in students' mental health that engaged with us. And so you can see here that there actually drops in their scores are even greater than the average drops across our book of business. And then a lot of students also then took their homework, took their activities, and went to see a counselor and said, hey, here's what I'm doing with Learn to Live. I'd like to talk to you more. So our programs became essentially a gateway to get people more comfortable with their mental health and focused on their mental fitness, and got them into some of the exceptional services that the university offers. We're able to help them improve their academics, so 19% are less likely to drop out. Almost half are more likely to ask for help in class. Remember that mental health can be incredibly isolating, and so it's difficult for students to reach out and ask for help. So that's really Learn to Live, kind of in summary and short form, and some of the work we do around the state. Appreciate you having us here today, and thank you for your time.